SilverEco Podcast presents Expert Thoughts, a podcast recorded during the SilverEco International Festival at the Palais de Festival in Cannes. AAL Legacy, 14 Years of Innovations for Aging Well. This episode focuses on the European AAL program and the key lessons learned from 14 years of innovation aimed at improving the quality of life for older people. With the participation of Geja Langerveld, advisor, ambassador, board member, senior and technology expert at AAL, Dominique Repapis, senior manager of European programs at AAL.
Okay, so good afternoon, everyone. My name is Dominique Repapis. I'm the Program Operations Officer at AAL, so we will tell you a bit more about the AAL program. And this is my colleague Geja Langerveld, and we are both here today to present the outcome of a study that has been prepared by our funding program. So we are a European funding program that has spent over 16 years financing and funding projects active in research and innovation for aging well. And so we're here to present the study that is now live on our website, and there's been a full report, but the idea today is to give you some key messages of things that we have learned that could be useful for future programs, policies, and potentially, even project participants. Welcome, bonjour. So yes, Geja, maybe you can introduce yourself and we can start.
Well, thank you, Dominique. I'm Geja Langerveld. AAL means active and assisted living. I think it's nowhere in the presentation, so maybe it's good to explain it. I don't know if you are familiar with the program or not. As Dominique said, we have been working over 16 years on this program. And, the background, I suppose you are all aware of it because you are here and you know about the topics that are relevant. The average life expectancy is in 2070 88. The European population will be about 1/3 of in Europe, and the ratio of the people financing the taxpayers and the pensionados are kind of balancing the other way. A pyramid would be like that, and now we have it like that. So the population is changing, but I'm sure you are all aware of that. AAL was a funding program, and it had three objectives from the start. That was to improve the quality of life of older adults by using digital ICT-based systems and solutions. The other one was to support the sustainability of health and care systems. Of course, already in 2008, studies were done, projections were done, and we knew how the population situation would be by now, and also how the projections of the care staff available would be. So that was not really looking very good, and we thought we have to do something about it. And then the third one was that we should foster the industry in Europe, the companies and also the SMEs and the startups, to provide for these solutions, because otherwise everything it will get here imported from China, from America, everywhere, but it would be good to have a European industry as well. And I think recently that became all the more important, especially with all the AI developments. Well, short overview, the program ran in two parts, AAL1, AAL2, all during 15, 16 years. We had 14 calls launched, funding over 300 projects. We had in the beginning, 23 countries participating, some countries with different funding agencies, but that reduced later, but we still had, 23 funders, being either national funding agencies or regions, especially in countries who have kind of independent regions who have their own policies and their own funding for health and healthcare. Altogether, participating in projects were more than 100 user organizations involving many, many more end users, being either older adults or informal carers and professional carers. We had 700 R&D organizations participating and over 2,000 SMEs, and over time that kind of became more and more. Parallel to the project funding, discovering what kind of needs the project partners had to really not only develop solutions and do research, but really bring them to market. Well, we discovered or detected, or they told us what they needed, and we launched a lot of support actions like a market observatory. We did an end-user study to list all the types of methods that you could use to engage end users, especially older persons. We did a big one was AAL to Business. We come back to that later, supporting consortia and companies to really go to market. And altogether, national and EU funding, and I guess also the private funding that was mandatory from the participants. We spent over $1 billion, so that is really a lot of money. That's why it's important to leave the products and the solutions, but also the lessons that we learned over all that time. Then we launched a study. It was commissioned to Idea Consult, and they used artificial intelligence, a large language model. Don't ask me how it works because I don't know, but that was what they used, analyzing thousands of documents of the projects, of the program, evaluation, reports, impact assessments, support everything. This system generated insights that we, for a big part, could recognize with our own experience. I worked for more than 15 years. Oh, I didn't even introduce myself. No. I worked for more than 15 years in the Netherlands at a Dutch funding agency as the AAL coordinator or program manager. We had a group of experts that went through the reports and signaled strange things that we couldn't recognize. So expert validation was used to improve, so to say, the findings from the AI system. Well, I said already we used endless numbers of documents to answer 17 evaluation questions. I'm not going to list them all to you. You will see the results throughout the presentations. And still, although I think we went 3 times scrutinizing the document, I think we kind of kept out the AI hallucinations, but you never know if some inaccuracy still remains in the full report.
This is to say that if you feel like reading the 135 pages report and you see something strange, it might happen, but it shouldn't. And you can contact us, of course.
Well, one big element in AAL projects, and that was mandatory from the very first call, was the engagement of end users, being at first older adults. And we made it mandatory in the sense that one of the eligibility criteria in projects was that they had an end user organization involved. So that it's not just, a university gathering some older adults together and then they have fulfilled that criterion. They really had to involve an end user organization. They were usually, responsible for involving individual people. Over the whole period, more than 60,000 older adults participated in different stages of these projects. Over 14,000 caregivers were involved that were either informal carers or professional carers. In the beginning, there were surveys, so that was accountable for a lot of end users. You can spread them out widely. There were focus groups held, and there was long-term pilot testing involved over time. So we really try to generate inclusive and practice-oriented innovation. So not only, research, but really practice-oriented so that you could come up with solutions that were usable, useful. And you see that over time very clearly from the analysis. It started with brief consultations, then there became more collaborations with end users. And in the last few calls, there was really long-term, like half a year or sometimes even year-long testing and evaluating of the solution in practice situations. Well, at the last calls, over 50% of the project practiced really co-design methods, not only surveys, not only focus group, but really iterating in different loops the solutions that were developed. Please come and join us.
Hello.
Following development was that over time the public sector was more and more included. Municipalities were in some countries responsible for care for older people were involved already in early phase of the program, but many more were engaged over time. And it sometimes were also housing bodies or residences for seniors and insurers who are often responsible for funding not so much of projects but much more of the day-to-day using of the solutions. So the user engagement were really cornerstones for success. Continuous, structured, well-organized, repeated feedback loops, embedded testing that really led to stronger outcomes and late stage changes. I mean, if you start a product and it's almost finalized and then you discover that it's not really working, then you spend a lot of time and money without much success. And the long-term testing also created higher trust. And we can even see that when these factors were missing, that even very promising solutions just couldn't get any further. They just stuck at the end of the project because there was no system around it that could take it up. Then we have the challenges. Every year we launched a call with a theme or a topic. Topics like one call was about promoting social interaction, the other one was about supporting mobility, the other one was, like that. That was what we did in the first calls. And later on, when AAL2 started in 2014, we changed that into more what we call challenge-based calls, like living well with dementia or better managing chronic conditions. And what you see when you define it as a challenge, and that corresponds very much, of course, with daily life of people. If people are mentally declining, you don't need support in only one topic. You have some day structure needs to live independently. You might have some navigation support to be able to move around in the environment. So these challenges made it possible to really integrate different components from different life domains into more integrated solutions. Number of times such a challenge was addressed. It's not that they're adding up to 100% because many solutions address, as I said, different topics, and then social isolation and loneliness was a very important one, as well as daily living and independence, because that is where the real challenges are when people get older, are starting to suffer from some deterioration and still want to live independently. So, promoting social connection and emotional well-being was supported by communication technology, community creation, calling people to shared activities via digital solutions. So all aiming at engaging people in their social environment. Daily living and independence, what I said, day structure enabling everyday tasks, safely providing reminders to things like medication or eating and drinking or appointments or things like that. Then we had the third one was cognitive decline and mental health. That was actually quite a broad topic because it, on the one hand, is memory loss, a general characteristic when people are aging, but also a lot of people with either starting dementia or cognitive. And that is really a topic where these AAL solutions are, there are a lot developed to support people with having to deal with memory loss, because it's a very kind of clear need, but on the other hand you need very flexible solutions because people become more and more affected by that. Also including cognitive stimulation by games or by exercises and also therapeutic systems were developed. Have you been on the floor? Is it this floor or the one up?
We're up.
Oh yeah. Well, there are of course a lot of booths anyway, but there are also 5 booths from AAL projects or solutions. Well, then of course a big topic was the physical and functional mobility, rehabilitation. There's one upstairs, fall prevention, fall detection, and there are technologies that are, well, wearables, robotics. There is a lot possible to address that particular topic. Safety and emergency, always from the beginning also, well, not in all the projects, but a very clear need to address. That also has to do with the detection of falls and health crisis. That's much more about monitoring systems. And then another big issue is the reduction of the burden of caregivers, especially informal carers, but also professional carers. Chronic disease management, also monitoring, early warnings, coaching, some cases also early detection of deterioration. Then there were some projects addressing environmental adaptation with smart lighting, sensors, which can detect falls. Sensory impairments, there were not many. I remember one project where they tried to develop a smart stick for people with vision impairments, but there were only few projects addressing those topics. Well, what we saw over time is that we started, and that of course is related to these calls from single purpose, from basic sensors, basic systems, to really complicated integrated systems with predictive AI incorporated in the solutions. What also helped was that over time, more and more the standards, the interoperability standards were developed, respected, deployed, or how do you say that, implemented. So that means that also the island solutions, from only facilitating social interaction to ecosystems where you could plug and play all the different types of solutions that someone might need, you can tailor that to individual needs. And that is really an improvement, and also necessary, because otherwise it will be people need like 5 different interfaces to deal with the different challenges they meet, and that's a challenge in itself, I think. So we moved from single topic to broader challenges, and in the end we ended up with more integrated ecosystem level solutions. Then another mandatory aspect of this program, but also objective, was develop solutions and bring them to the market. Because if they stay in the research area, well, it's interesting for researchers, but no older adult will benefit from it, nor a care system. So we had this commercialization line in the program, where we also demanded that at least one SME should participate in a consortium, aiming at bringing the solution to market. And what you saw was when user engagement was well organized, when the open system design was okay, so the possibility to plug in new other solutions, and the structured business support that was also developed and provided by the program. If that was in place, then they really, at the end of the project, succeeded in follow-on funding and deployment. And when some of them were missing, a lot of projects died after the prototype. You saw also the rise of SMEs by supporting the projects, training them, workshops, coaching, to develop business models, to get access to finance, to learn how to pitch for investors, for instance. All that type of support really helped, and it also made the number of SMEs participating really wanting, to use a project to bring a product to the market. evolved over time, and at the end of the program, 2/3 of the project coordinators were SMEs, and in the beginning, I think almost 100% were research organizations. I think we mentioned already isolated pilots. That was another aspect. Over time, we also realized that we saw a lot of projects developing. Most projects lasted 3 years. After 2 years, 2.5, you actually could see that they learned a lot, but they were not able to really get further to the market. And we realized we should create new opportunities, like small collaborative projects of maximum 9 months, right? Or 6, 9 months. Well, much smaller funding, of course, but that was made it possible to explore on an idea and test if that was well accepted, and then if that was successful, then you could build a big project to really build the solution. Or what also happened is that, for instance, companies that have a product that was used in a certain domain realize, this could very well be used also in this sector where you can support people to live independent. For instance, from the energy sector, or from, I know one of the first projects that was from in the Netherlands, from the defense sector, surveillance solutions, and thought, we have this advanced technology, why can we not make it available for safety and security of people at home? So, and then via the project, they tailored these ideas and these solutions to a useful product. And again, the horizontal business services, what I mentioned there, but we really spend a lot of time and also money on supporting projects to learn business aspects. Yeah. No, the lessons learned. Well, we have lessons on program level and lessons for health and care innovators. We thought this audience is mostly interested, I guess, in the last group. So the first one is start with people, not with technology. Unless you want to, what I said, what you can do is you have a technology and you want to explore if it works in the sector for all the adults to stay independent and have a better quality of life. But even then, you start with investigating what they want, what they need, and then see if your product fits in, and not the other way around. Build for integration, not isolation. I mentioned that, and I explained that already, I think. Well, another one is anticipate regulation. Over time, a lot of regulation came up, like the GDPR, AI compliance, MDR, and if you only start halfway or later in the project to realize that you have to comply to that, you have lost a lot of time, but also maybe already made a lot of errors. Test in the real world, so not only in a lab situation, where actually it might be good, especially I heard that often in projects for people with dementia, make sure that you first test with people to make sure that your solution is working good when you start really testing and implementing it for people with dementia, or because they get completely confused if errors come up in the screen, or the system is just not working well. So a real test in the real world, but be sure that what you provide to people, especially people who are mentally a bit challenged, that they get real solutions to use. Align with payers, also very important. What I said earlier, the public sector and the care is important to include, because they are, for many things, the ones who are going to pay, and it has to fit in their strategies and in the reimbursement systems. Design for inclusivity and localization. We walked around here and almost everything is in French. And in France, that's okay. But if you want to go international, it doesn't
has to be inclusive.
Yeah.
Yeah.
So if you want to test something in, wherever, in Netherlands or England, and most things are in French, it won't work. diversify dependencies and revenue. Yeah, that is, well, it's kind of obvious maybe, but still, being dependent on one company to provide part of the solution is risky. And also, you have to really try to find a good blending of financing, again, not the project, but who is going to use, is it a consumer product? Will the informal carers pay? Will the organization buy it for all its clients? You have to find a good balance to be able to really scale. Leverage existing support structures. I think that is now you have a lot of ecosystems of companies, funders, care organizations, etc. So really try to get all the support that you can become a partner in such a network. And the last one is plan for after the project. Because if you start doing that when project is finalized, many partners will have been gone, they have other projects, and you kind of end up alone with your product. So that's really often you need to make already agreements with partners about future collaboration, about IPRs as well. Yeah. So that are the main lessons that would be good to take into consideration. They're on a quite generic level, but still, I'm an evaluator in a Dutch program now since very recent, and I realized that in their calls and in their criteria, not all these things are fulfilled, and then it's really difficult to assess projects that look very promising as positive if really crucial parts are missing. So I'm really curious about how that will go, but I will really try to spread this message, because it's really, there's a lot of data in it that kind of prove that these are important elements. Yeah, thank you.
You will find on our website a webpage with all these key messages more developed. And if you feel even more motivated, then you can read the full report, which is very interesting. Thank you for joining.
Okay, thank you.
Thank you very much, and we're happy to see you later on upstairs. Thank you.